As Eric had mentioned, it's amantadine. So in the past, we did amantadine with a very particular focus in looking at its usefulness with schizophrenia. This was a little bit of a step back to kind of take a broader look at the use of amantadine. So what we're going to cover today, just a quick recap of the mechanism of action and the adverse effects. So what might this be useful for? How does it work? And then can patients tolerate it? Because if they can't, then maybe we can't see other uses. And then we're going to look at a little bit of a broader picture of some of the places where amantadine's been used. So first things first, if we are using amantadine, what is it that it's doing? So it has actions on glutamate, dopamine, as well as acetylcholine and norepinephrine. So the glutamate actions, it is a weak non-competitive antagonist of our glutamate N-methyl D-aspartate, so the NMDA receptors. So decreasing some of that glutamatergic activity may potentially help with the neurotransmission of some of our other neurotransmitters, including dopamine. So it really seems to be pro-dopaminergic. Working on the glutamate may enhance the amount of dopamine that's available. It also seems to inhibit the reuptake of dopamine and may actually promote some dopamine release in particular parts of the brain. We also have some action on the acetylcholine receptor. I point this out because we're going to talk about cognition, and it seems like it should be counterintuitive. So it does have some antagonism at the alpha-7 nicotinic acetylcholine receptor. Although this doesn't look to be incredibly, it doesn't look to be irreversible, and it's non-competitive. So it is able to be displaced by other things. So potentially maybe attenuating some of the acetylcholine effects, but not necessarily shutting everything down. It also is suggested to have some norepinephrine reuptake inhibition, again, relatively small amount of activity, but that may play a role in one of the uses that we see a little bit later on. So if this is how it works, in looking at some of the neurotransmitters, how well is it tolerated? What do patients experience when they're taking it? So from the adverse effects standpoint, there are a handful of them that patients do experience. Those that are bold tend to be reported more frequently than some of the others. So some anticholinergic effects, so things like constipation, dry mouth. We do see some dizziness and orthostatic hypotension. So ensuring that patients are conscious of that as they start taking the medication and that they're able to slowly move their posture from laying to sitting and then sitting to standing. Insomnia does tend to be problematic, although in some patients who are on other medications that are incredibly sedating, that may be something that they find helpful. The nausea, while it's reported in about a third of patients who start on the amantadine, this does appear to be transient. So if patients can continue with it, they tend to be able to tolerate that a little bit later in their therapy. The good news is that despite the, I had one more thing I wanted to say on here, and I started and I still skipped it. The psychosis, so it is somewhat pro-dopaminergic. There have been reports of psychosis, hallucination, delusions in patients without a mental health history, as well as an exacerbation of symptoms in patients who do have a mental health history. So it is something that we need to be mindful of as we're starting this medication to make sure that your patient isn't one of the sensitive ones where this may make some of those symptoms worse. The good news overall is that amantadine does tend to be relatively well tolerated. So there was a meta-analysis done. It included just over 400 patients. Many of these were patients treated for Parkinson's disease, as well as those that were given amantadine for the treatment of movement disorders who were on antipsychotic medications. So in these 8 trials, when they pooled the data, there really wasn't a significant difference in discontinuation rates compared to placebo. So side effect wise, it was about the same. And for lack of effect, it was about the same from placebo. So if amantadine is going to work for the patient, it appears to work. That's not one of the reasons why patients stop taking it. On the beneficial side, as I mentioned, we did see more insomnia with amantadine, which in some cases may work in our favor if patients have a robust medication regimen that's very sedating. But it also has been shown to increase weight loss compared to placebo, and we're going to look at this in just a second. So overall, relatively well tolerated. Patients seem to be able to maintain therapy and not have to struggle with some of the long-going adverse effects. So recognizing that it may work on some of our neurotransmitters and it's well tolerated, where might it fit in? And this is really where I wanted to kind of take a step back, because amantadine's come up a couple times in discussions throughout this last year. I think we talked about this last August with a little more of a focus on the psychosis symptoms, but I wanted a broader look at where might this fit. So there's a handful of places where we can see it. Unfortunately, because of time, with the blitz of our didactic to allow ample time for discussion, we're going to focus on some of the areas where it's most prevalent, where we have a lot more data, but that teaser with the symptom improvement, I did want to look at some of the other areas where we had some evidence. Amantadine does have FDA approval for its antiviral effects against influenza. We are not going to cover that today, a little bit outside what our scope is. So movement disorders, one of the other FDA approved indications. So really, I think where traditionally a lot of individuals started feeling comfortable with the use of amantadine in patients with mental health diagnoses. So there is an official approval. So the Osmolex ER preparation does carry the official FDA approval for treatment of drug-induced extrapyramidal reactions. So even though we've been using some of the other preparations, this really got the official blessing. I just wanted to point out one thing with a number of our other amantadine preparations, they are immediate release. So it's something that they may see a pretty significant peak. So if patients have trouble with that, that could be problematic for them at times. So the Osmolex ER is one of our, they call it Oros technology. So it's one of the preparations where the outside layer actually dissolves. It dissolves relatively quickly within that first half hour to hour, releasing some medication. And then there's a non-soluble shell that has laser drilled holes. So the water from the gastrointestinal tract can get in there, and it activates almost like a, what they call a push cavity, almost like a sponge that expands and is able to push the rest of the amantadine out. So that's how they achieve their extended release preparation. I point that out just if you have a patient, and I recognize coverage is an issue with this, it tends to be expensive. But if you do have a patient that's on this, they may report that they see the shell in their stool. Yes, they might. The shell of the tablet itself does not dissolve, but the medication from the inside would be released as a result of that. But despite the fact that we have a relatively newer official FDA approved indication, for almost 40 years, there have been reports of improvement with movement disorders in patients who have movement disorders from the dopamine antagonists that they're using for nausea, as well as those that are used for mental illnesses. And there are a number of reports where they see improvement in the movement symptoms, regardless of whether or not they're predominantly Parkinsonian. And I think that's an important distinction to make, because sometimes we associate amantadine with just treating the Parkinson's, but it has been reported to be effective, and the approval is for more than just those Parkinsonian symptoms. Interestingly, as I was going through the literature overall, I did come across a trial that compared it to benztropine. So it was a relatively small double-blind crossover trial that looked at amantadine versus benztropine, and they did not find a difference in the clinical evaluation of movement symptoms between the two. Although there was an impression that the patients did better with benztropine, although for some of the patients, they may not be able to tolerate those anticholinergic effects. So interesting that one of the a little bit older, but one of the head-to-head trials said it may be somewhat equally effective. So looking beyond just the Parkinsonian symptoms, we do see improvement with tardive dyskinesia. I like this trial because it is a little bit more solid from a methodologic time frame. So it was only 2 weeks, randomized, double-blind, placebo-controlled. Patients did have tardive dyskinesia, and they saw significant improvement in the AIM scale when they were given the amantadine. So again, really lending some credence that if we do have patients that are struggling with some of the movement disorders, amantadine might be one of the agents we want to make sure we're ready and comfortable with to offer them as an option. So beyond movement disorders, what else do we see? I think one of the main areas where there was a lot of excitement is looking at weight loss. So amantadine has been added to different antipsychotic regimens for its impact on weight reduction. This has been true even in patients who are on antipsychotic medications such as olanzapine that may be more likely to result in the weight gain and unfortunately maintenance of that weight gain. So we do see a mild to moderate improvement in patients' weights once they're initiated on the amantadine. We did not see that with the memantine, which is the top part of this. This came from a meta-analysis. So amantadine may have a little bit of a benefit. Some of it may, and many of these were short-term trials. Some of it may have been, as is argued by the authors, from the nausea from starting the amantadine, but even in those that last a little bit longer, 6, 8, 12 weeks, there does seem to be an improvement in weight. So potentially as an option to assist with weight reduction in patients who may be struggling with that if their antipsychotic medications are beneficial, but they did gain some weight. So areas that I think we traditionally start to think of amantadine, now we're going to start to get a little bit farther off the path. Cognition, so there is some evidence suggesting that amantadine may assist with cognition, although it may play a very discrete role. So this was a randomized double-blind placebo-controlled trial that was 12 weeks in duration. So they did use amantadine, 400 milligrams or placebo. Some of their main cognitive findings, there was no difference between the amantadine and the placebo. They did find some statistically significant improvement on the Hopkins verbal learning test. So patients on amantadine actually perform much better with some of the verbal learning and memory. This may be why we see additional improvement in some of the patients with traumatic brain injury, where they have been trying to use amantadine, and there are some case reports of improvement in cognition for some of these patients. So helping with some of the processing, but maybe not completely across the board. There was a meta-analysis that was done looking at the use of amantadine in patients with schizophrenia or schizoaffective disorder, and they did see a mild improvement on the mini mental status exam, so that patients who were on amantadine did better than those that were on placebo. This was a limited number of trials. It also was not long-term, so in patients who potentially were incredibly sedated or may have had other adverse effects, might that be part of the response that we see here? It's a possibility, but it does look like it has some improvement in cognitive functioning. And that's despite having that antagonism at the nicotinic acetylcholine receptor. So just something to keep in mind, that this may actually be a little bit beneficial, but probably not going to be enough to really push their cognitive function into a clinically significant territory where they see tremendous, tremendous improvement, just if they have schizophrenia or schizoaffective disorder. So other areas that amantadine has also been used. And I just wanted to pull these forward because I do think it's interesting, and most of these did have a number of publications related to them. There have been quite a few case reports that demonstrate improvement in catatonic symptoms in patients who were given amantadine. So in some cases, all of these were inpatient. In some cases, they were patients that were initiated on other treatments, including antipsychotic treatments, and did not see any improvement in catatonia, and then were added amantadine. In other cases, it was amantadine used monotherapy after other treatments had failed. There were there was at least one case series that demonstrated improvement in the catatonic symptoms that then and the catatonic symptoms recurred after the amantadine had been stopped. So the amantadine had been stopped, and within the next 24 hours, they actually saw those symptoms come back. So they reintroduced the amantadine, and again, those symptoms resolved. So in some patients, this may be a potential option if some of our other traditional treatments have not been beneficial. Other places that we see amantadine being utilized in patients who have sexual dysfunction. So these were patients who had sexual dysfunction as a result of their antipsychotics. It was an open label trial. It was outpatient. It was all males. And it was a duration of 6 weeks. And they saw a significant improvement in most areas of sexual functioning. So their arousal, their satisfaction, as well as their ability to maintain an erection were all improved when they had been treated with amantadine. Their ejaculatory function was the only area that they didn't see improvement in when they had the amantadine. So if some patients are doing well, have been stable, but really are suffering from some of these long-term adverse effects that we know happen with our antipsychotic medications, this may be a potential option to assist them with that. In none of these patients who all had schizophrenia or schizoaffective disorder, they did not have an exacerbation of their mental health symptoms. The other 3 areas I have asterisks on because there is a little bit of discrepant information that's available. So for NMS, the neuroleptic malignant syndrome, there are case reports that go in both directions. So case reports of patients who were initiated on amantadine, who then developed symptoms of NMS and required treatment and discontinuation, as well as case reports of patients who developed NMS and then were given amantadine and had resolution of those symptoms. So small number of cases in each case, but there tended to be a relative rapidity, so a very short duration. When they started the amantadine, it was not long after that they saw the exacerbation of those symptoms. And similarly, patients who were admitted, who were then administered the amantadine, they actually saw improvement of their NMS symptoms relatively soon after. So an interesting population to think about if they are on if they are starting amantadine or if they're suffering from those symptoms and not improving, another potential option that we may have. Maybe a little further down the treatment regimen, but interesting nonetheless. The last 2 areas, so there's quite a bit of information out there looking at amantadine use with agitation. There's a lot of interest in the area of traumatic brain injury, the potential role that amantadine can play in neuroinflammation and potentially having long-term beneficial impacts for patients who have TBIs. These particular, one was open label, one was a case series that looked at TBI patients who were administered amantadine. They did see improvement in their agitation symptoms. Some were relatively soon after the injury, some were a little bit later. They had had the traumatic brain injury for a while thereafter, but they did see improvement. Not in all of the patients, but in more than 50% that were reported. And obviously it was open label in a case series, so if they saw the improvement, they did that. But an interesting thing to think about. They've also used this in a number of patients with autism spectrum disorder. So in one of the outpatient trials where they used the amantadine, they actually didn't see any improvement from the parents' perspective in changes in the agitated behavior, but from the clinician's perspective on their rating scale, they did see some improvement. They then went on to do a later trial on an inpatient unit. So patients that had much more severe agitation and were, had an autism spectrum diagnosis. And in that case with the open label trial, they did see improvement. And there was one retrospective case study where they did see improvement with the addition of the amantadine. So a population where maybe we wouldn't normally think of adding the amantadine, but it may potentially play a role if we haven't gotten efficacy with other agents, or if tolerability tends to be a big problem. The last area was actually the area that started me looking at, hey, let's take a bigger look at where amantadine may be used. So there's been a recent publication in the last year or two that's re-evaluating the use of amantadine potentially for the treatment of depression. So there was a meta-analysis that was done that looked at both animal studies as well as the limited clinical efficacy data that we do have at this point. So there's less than 10 trials that have been done looking at amantadine for depression. They tend to be open label. They tend to be between 4 and 8 weeks long and relatively small sample sizes, so not incredibly robust. And there are some inconsistencies, but the patient population was also different. So in some cases, it was used in patients who were refractory, who had failed at least 2, but in most cases 4 or 5 other treatments for depression. And in other cases, it was amantadine that was added adjunctively. So in patients who just hadn't fully responded to an SSRI or a tricyclic antidepressant, and the amantadine was added on board. So it does appear that there may be a signal for some improvement in depressive symptoms, although that's not going to be consistent and more evidence is needed. But just to let you know, there is some discussion and some interest in re-exploring amantadine's use in this area. So to wrap us up and finish up our blitz, amantadine's actions, primarily glutamate and dopamine, although we've got a little bit of acetylcholine and norepinephrine in there, and does tend to be generally well tolerated. Some of our best evidence is really with its use in movement disorders and weight gain, but it may potentially play a role in a number of other areas. So we may see amantadine continuing to expand a little bit its reach to assist patients. With that, we'll stop the share and turn it back over.